me introduce Eric PEDEN. He's the Chief of Vascular Surgery here. He and I have been working together in the department for 11, 12 years. And it's match made in heaven because he's interested in dialysis access and lower extremity occlusive disease. So you'll have a partner basically who's going to focus on that. But he's going to tell you a little bit about what we've been doing around venous disease.
Great. Thanks very much. Impressive to see so many people here still on a Sunday. That's great, Bill.
Yeah.
So I've got John Bismuth's name on there because he's originally created this presentation and honestly is responsible for a lot of the work and the content that goes into it. Stay tuned because I think next year he'll be back on the podium probably, and they're continuing to work on trying to age clot in the venous system, which for us has been a huge deal. And hopefully by next year he's made progress on that, which will have big therapeutic implications for us in terms of who we treat and don't treat. So he's got this slide up from the 1960s saying that basically, venous imaging is huge and it directs our interventions, and we still need better and better quality of images to figure out what we're going to do for patients. And that still remains true now, including that aging of clot that I was just talking about that's not there. So what are we looking for? Well, obviously the same things you've been talking about, right? Is anatomy and function and dysfunction of the structures as we're looking at it. And in the venous structures, we've got a few things that are a little different, right? We're looking for venous insufficiency or the improper movement of flow. We don't usually think about that on the peripheral arterial side at all. Obviously in the heart you are, but in the venous system that does mimic that because of the valvular function. Whether or not we can operate, whether or not we should operate, and whether or not the procedures we're doing are working out. So both benign and malignant disease are implications for the evaluation. So CT venography can be indirect or direct opacification, most times indirect, meaning injected somewhere else, then waiting for the contrast time to come through. And depending on the involvement of your imagers and the technicians and stuff, this can be either really gratifying and great images or really terrible images that just show you the arterial phase or what looks like no phase to the non-imager, which can be a real challenge. Being able to look inside a stent's really important to us, as we've just heard, particularly the smaller stents. The bigger stents, it seems like we can see through, but accuracy of in-stent evaluation for stenosis really important to us on the intervention side. And the MR imaging sequences are limited only by the alphabet, right? There's so many imaging sequences that can be done, both contrast enhanced and non-enhanced and flow dependent or independent, depending on the sequences that are set up. And again, that's why it's so important, I think, to be specific in when you're ordering the test and what you're looking for so the imagers can give you the best imaging possible for your clinical indication. I think for us in the surgical world, this makes a lot of sense to us. These image sequences are time-resolved MR acquisitions. Where basically contrast is injected and we wait and see how that goes through. It's got a variety of acronyms depending on the manufacturer and the particular sequence that you're looking at. But essentially it's this, right, that a subtraction mask is obtained, the gadolinium's injected, and it goes through the arterial phase of imaging, then ultimately the venous phase imaging. So that's a static position where it's recapturing imaging through the same area, and then ultimately wind up with something like this, which really sings to us as surgeons that we can then see the dynamic flow through the arterial system and through the venous system and actually make sense of where the problems are and how that correlates to the clinical presentation. So one thing that can be frustrating to us on the side that we're not so used to MR imaging is those of us who are looking at these and then see flow defects within the venous system and say, wow, is that clot that's there? But non-gated MR imaging, depending on what sequence you're using, it can look like a flow void and artifact, but in fact it's just an artifact. And if the cardiac gating is done, then it takes that away, at least in the 2D sequence acquisitions. So May-Thurner syndrome is something that we're quite interested in. So anatomically, know that many people have compression of the left common iliac vein where the right common iliac artery crosses that, and it gets pinched between there and the spine as seen down here. This anatomic issue is present in probably 20 to 30% of people, obviously asymptomatic in the great majority, but occasionally patients present with significant symptoms related to that. And the imaging of this can be really important. Standard diagnostic tests include non-invasive and invasive procedures that we can do to both diagnose and then treat these problems. So in almost every vascular surgeon's office around is a vascular lab using non-invasive imaging with ultrasound. And what we look for is indirect imaging by and large for this, because most sonographers are going from the groin down, not scanning in the pelvis where this problem is actually at. So what we look for is that the contralateral common femoral vein waveform is phasic or varies with respiration, whereas on the side that's ipsilateral to the problem, usually the left, we'll see that's non-phasic or continuous flow, and that gives us some indirect evidence that that's the case. If they'll directly look, and here you can see they're using the curvilinear probe, if they'll directly look, we can see that the crossing iliac artery here is we have a flow disturbance through the iliac vein as it's coming up to try and join the inferior vena cava seen by the colored flow disturbance. And then we can measure velocities through the area as well. But that's difficult to image, especially in somebody that's not so small. So CT can give us great imaging, but it's obviously static, right? We're not usually looking at dynamic imaging with CT. MR image sequencing can be really great for this, depending on the sequences that are run, because then we can see dynamic flow through this area. So again, it's looking for that same thing with compression there as the iliac arteries have come apart already, the iliac vein is crossing over and coming up to join the vein. As we go down to the pelvis, sometimes we can see collaterals or other things suggestive of that, as we'll see that we have cross-pelvic filling. And again, further imaging showing some compression. So Jean and one of our previous residents, who's now faculty up in Dallas, went through and studied our imaging abilities of this and found that MR was really quite good and set aside criteria. Previously, we relied on venograms alone, and these are images that I pirated from Raju and Naglin, two legendary guys in this field that work up in Jackson, Mississippi. So essentially, regular old venography before showing obviously dramatic occlusion of the upper iliac vein system on the left side with cross-pelvic filling like we were talking about and collateral flow up the abdominal wall, and then marked improvement of that after fairly extensive stenting. Because of the nature of these things, they would employ oblique imaging, where basically cant the eye further and further over until they can actually see, instead of just a haziness here, but actually start to see the outline of the iliac vessel itself as it's crossing over. Pretty striking. So then after stenting is done, even with oblique imaging, we can see that the stent is well expanded and the person doesn't have that issue of compression anymore. Another technique that was offered as well was diagnostic angioplasty, right? So actually putting a big balloon up and angioplasting the vessel if you were sure or not sure to see if this is an issue. Obviously, that carries some risk of injuring the vessel. We know that one of the great lab animal models of creating stenosis is to go up and blow a balloon up inside of a vessel that doesn't have any problems. So this may be not the best idea. IVUS can help as well. IVUS is actually the mechanism that those guys propose the most. So you have a venogram here. You have some evidence of some haziness here. You have some cross-filling. When they go through, and this is before and after intervention, when they go through and do the IVUS images, the IVUS catheter itself is the dark with the bright circle around it. The vein is actually this white thickened area, and it's just really compressed. After they put the stent in, you can see actually the vein is fully expanded. So this area can be much more compressed and stenotic than it appears on plain AP venography, which is one of the issues of getting additional imaging. So looking at CT and MR for our venous system as we go further into central veins is looking for artifactual defects, benign and malignant. So we like to know things like where's the left renal vein, is the normal iliac branching pattern, or do we have things like bifid or duplicate renal veins, retroaortic renal veins, in this case a duplicate IVC system where incomplete fusion has happened during the embryologic process. Malignant defects, fortunately, are uncommon, but when they come up are pretty dramatic. And to see those and be able to differentiate that from benign thrombus or bland thrombus, really important to us because obviously the approach is totally different. And to go into thrombolysis and stent this is obviously a great mistreatment of this patient. So MR here, like Faisal was talking about, obviously is limited by metal, right? So an IVC filter here causing a complete essential void there of the imaging, but with CT we can see actually trailing thrombus coming off of this IVC filter, thrombus within the IVC, and these are things that you may not pick up at all on regular venography, because if there's only partial thrombosis you'll see dye go past, and unless you're noticing a little bit of haziness there, it may not be so obvious. Dynamic venous imaging, we've talked about some. Here's sort of the tricks path that comes from our semen system, and we can see arterial disease right at the origin, and then venous system as it's coming through, and then the arterial system washes out and give us better imaging of that. So in this case, this is a patient that Jean had treated before who'd come in with some abdominal symptomatology and wound up having a tremendous AV malformation down the pelvis. She's these really hugely engorged veins down the pelvis that are far from normal. And using the imaging to try and figure that out, help them figure out where exactly this is coming from. Here are the reconstruction images, really a massive thing down the pelvis. So then with further imaging, you can see that the venous system looks like it's widely patent, so there's not obstruction there. And then with further imaging through the arterial system and subtraction delayed imaging, you can see actually the venous phase enhancing and these large collaterals and this huge AVM coming up from the pelvis. So sort of on delayed imaging with road mapping from the SMA, and then allows them to direct intervention from that. One of the challenges for us, again, as sort of a non-imager, trying to use these images to plan things, is seeing images like this in the middle, right, where we see that it's kind of arteries and veins all mashed together, which is a real challenge. And that's where the intense involvement of your imager and helping them with the image acquisition and sequencing is really important, because we may be wanting to focus here on the venous or here on the arterial, but very unlikely are we to want both, right? So looking at the contrast arrival time and the image acquisition and what they then display out to us, really important, so that we can either focus on the early arterial imaging or the delayed venous imaging that comes up. IVC filters have been all over the news. You search that on the internet, the first 500 sites you come up with are all lawyer sites, right? Somewhere on that is our own call to the patients to come back and consider getting these things done. So for a while, it seemed like a great idea to go and put retrievable filters in patients because they had a temporary problem, but it turned out that the overwhelming majority didn't get these retrieved, and many of these filters, especially the early generation ones, had problems, right? So they tilt and go outside, they break apart, they move, all kinds of stuff. Sometimes they move downwards, which almost defies logic. But all these things happen. So it turns out that there's a lot of dynamic issues with the IVC. And our guys have done a study here just watching through the cardiac and respiratory cycles of how much the IVC can change and whether or not that can imply some difference that should be applied to the placement of filters, or if the filter is actually indicated, to say should we not put that. And what we found was that there was significant variation through the cardiac and respiratory cycles, not even to mention just the hydration status, et cetera, of how big the cava appears. And each of these filters has limitations in terms of what size filter it can be accommodating. So venous pathology happens for lots of reasons: clots, scar tissue, damage from us, nursing, etc., catheters, wires, trauma, whatnot, and then leads to all kinds of problems, and there's anatomic variations. So we know that when patients get these problems, there have been variable results in terms of how the outcomes are for the interventions that we offer, and we think that sometimes this is not understanding actually what the problem is. And this is a patient with recurrent failure, recurrent failure of their access and recurrent arm edema, who then goes on and has this intervention done. But we'd say, wow, that location is that thoracic outlet. And that's one of the things we always have to think about when we're involving the subclavian or brachiocephalic veins and interventions is this some kind of problem? So thoracic outlet, recall, is where everything's trying to get from outside in the arm, right, where things are relatively free, and then slide under the muscles, over the ribs, under the collarbone, through the neck muscles, right? And we got lots of neck muscles that are kind of helping to turn our head, et cetera, and then back down into the heart or up into the spinal canal and back up into the brain. So all these structures can get pinched, and we think most people with thoracic outlet have nerve problems, right? So tingling, et cetera, the fingers, it usually is happening more related to the muscles in the first rib. But for the patients that we see with arterial and venous problems, it's most commonly the vein that gets affected, and it gets pinched between the collarbone and the rib, and you can easily imagine why that would be the case, plus the muscles that are involved here, right? So the anterior scalene muscle is behind, pushing this forward and pushing the artery back, sometimes an aberrant cervical rib, and then also subclavius muscle can be a really thick structure. And just angioplasting this area or putting a stent here can be very ineffective because obviously you're not going to be able to defeat those bones with most of the products that we have. So in this patient, we'll look at that and see stenosis, is that TOS or not? So if we'll look at intravascular ultrasound, lots of movement here. As the probe is brought back, we're looking for luminal defects. And we see that catheter traversing from the other side, but we don't actually see, and we see this material here, but not a big bone that's compressing that. So that's a person that'll probably do okay with angioplasty and stenting. In this case, we see actually the rib crossing right behind. And if you'll notice on the left side, as it goes through again, on the left side of the screen, you'll see, in just a sec when it comes back, this sort of white bowing end structure with an intense shadowing, and that's actually a rib that it's going to come and compress from the other side. Later. let's see, actually, this next one shows one as well. So we see this big bowing and then big shadowing behind it. That's indicative of a bone, right? Because ultrasound doesn't pass through the bone. And then we can, with our plain imaging, we can go through and do flow modeling and look at how the flow characteristics are through there and then see what that looks like. I've got a case where something's been presented actually to the hospital just now. So IVUS we think is nice because we can also get stenosis grade as we can with venography, but we actually get to see better the inside of the vessel and what's going outside, and particularly the outside in terms of, is there a rib there? Is there something else that's externally compressing this? Because when we're thinking about the treatments of angioplasty and stenting versus rib resection, that's obviously a pretty significant thing for the patient. Here's a patient that's in the hospital now, actually goes to an outside hospital, is diagnosed with a DVT in the arm, and is found with this, right? So a catheter is coming from the left arm, coming up and injecting down here, and we see stagnant flow, we see mixed clot and contrast here. After a day or so of thrombolysis, we see improvement of flow through here, but sort of haziness here in this area, brisk flow coming down through here, but stagnant flow out here in the arm. So a stent gets placed at the outside place. Here it is. And unfortunately, stents in this area, as I was talking about, just simply can't stand up to the effects of the rib and clavicle. So as we look here, here's that stent coming through, and there's thrombus hanging off the end of that stent. And then down inside, see if I can play that. Actually, the next image shows better. So here are the coronal reconstructions. We can see actually thrombus within the stent here, and then thrombus trailing into the central veins coming down here. Not ideal in somebody in their 30s, or any age, honestly, for that matter. So knowing that and seeing those anatomic issues either with IVUS or CT or just the clinical intuition, really important, because this is obviously a real bad problem. This person had to go on and have clavicle resection, subclavian vein resection, repeat thrombolysis, et cetera, and put them up for a number of procedures. Central venous recanalization, something pretty important to us. We take care of lots of dialysis patients, to the disheartening dismay of my patients many times. And the central venous catheters lead to lots of obstructions in these. And here we see this. So this person's gone through and had MR imaging, and then that's been fused into this to try and help with recanalization and trying to reopen these veins, because this is one of the real problems for these folks, is that they weren't out of upper extremity access, wind up with things down their legs, which is not so ideal. With targeted recanalization, though, many times, this is actually using the robot as well, with the overlay and the presence of the robot helping to better direct these catheters and wires so they can go across and achieve something. Here's a challenge as a patient with really no obvious path to follow. Many times with angiography alone, we can figure out where this obstruction is or near obstruction and get through that, but sometimes we need further imaging help. So the patient undergoes the MR scan, basically then to delineate that, and then has the overlay. We'll then go to the operating room to create an image using the bony landmarks and then provide that same overlay and fuse the images together. That can be hugely helpful to us in terms of cannulating difficult vessels, or in this case, recanalizing, and then basically go through and have successful reintervention. This is a case then where Jean's done that exactly, gone through and projected where that track should be based on the position of the catheter and other landmarks, and then successful recanalization, angioplasty, and then restoration. They've looked at their abilities to fuse those images together in a series of several patients where basically they were unsuccessful previously, and then with image fusion and specific guidance, we're able to recanalize all those patients. So endovascular treatments for us remain sort of our first line imaging, perioperative imaging, or pre-op imaging, and then post-op imaging, hugely important for us. And the imaging approach really helps to guide our interventions and treatments for these patients. Thank you very much.